My name is Allie Orwig, and I'm with the Indiana Rural Health Association. Greatly appreciate everybody's time today, and just very excited about our presentation. Did want to do a couple quick housekeeping items before I turn it over to Shane. The first is that we are recording today's session. So if you have to leave early, or if you think it's really fantastic presentation, you want to share it with a coworker or colleague, we will have this up by the end of the week on our YouTube channel. So feel free to check back there by Friday, if not sooner. Also, during the presentation, Carolyn Miller and myself will try to keep an eye on the chat function. If you have questions, please use that or the Q&A button to submit your questions. And we'll kind of act as moderator during the session. Both of those can be found by hovering your mouse either at the bottom or top of the screen, depending on which view mode you're in. And as I say, we will try to send those over to Shane as the presentation is progressing. So I really think that is everything I had to say. Just appreciate everybody. This is my first time back for a while, so I apologize for the rambling intro, but we'll go ahead and get today's Lunch and Learn started. So without further ado, Shane, the floor is yours.
All right, thank you, Allie. Go ahead and get started here. Can you see my screen okay?
Yes.
Perfect. All right, again, thank you for the introduction. My name is Shane Grivich. I'm the co-founder and chief strategy officer at ChartSpan Medical Technologies, and with me I have my colleague, Karen Cosgrove. We're really excited to be here today, talk to you a little bit about an exciting topic here for this new year. Really the topic is Medicare's big CCM investment for 2022. When we refer to CCM, we're talking about the Chronic Care Management Program. So as we kind of go through this, we want to provide a little bit of background on really why the program was designed and really kind of the genesis and for what it was trying to create. When we think about value, really the way we kind of look at value within the healthcare industry is really the patient outcome divided by really the cost of delivering those outcomes. And that's kind of really what they've built the value-based care revenue programs around. As we think about healthcare, for pretty much the way it's been for most of our lives, it's really been more of a reactive journey. You have an issue, you go through the linear process, and then you finish that journey. But what we found over time is that we're really moving into inserting preventative type interactions throughout that journey, especially with the Medicare patients. And so, the innovation departments with CMS have come up with some really unique programs that have really shown to impact this journey. Things like the annual wellness visit, being able to identify care gaps and providing that self-reporting tool for patients, and then ongoing type programs such as the Chronic Care Management Program, where they find that providing ongoing care coordination in between office visits is proving to be a very successful component of creating this journey that's helping provide improved overall outcomes, reducing overall cost to spend for the patients, throughout a more interactive journey versus just a reactive one. When we think about, the cohort of patients that all of us, serve at these organizations, they really kind of fall into different categories. And so for years, we've had in place really the case management type program. And so think of this as patients that are home ridden, require home health, really are high acuity, disease states. And so for that, cohort of patients, case management is really what's needed for those, bolting on a nurse, that type of thing. But where Medicare felt there was a gap was really these middle and lower tier risk tiers of patients that had chronic disease states, but maybe had not yet moved into the high utilization stage. And so the idea around that was really to provide a program that could really produce an interaction with these patients that would help to reduce unnecessary ED visits, put them on a path to being more engaged with their healthcare and their providers, understanding the needs of these patients so that they didn't move into the rising or the higher risk categories. Here at ChartSpan, what we've been able to do is over the last several years with the CCM programs that we've run, we've been tracking data that Medicare has been producing for us. And so we wanted to show a few slides here that's pretty exciting that we've been able to evaluate. And it really goes to show you that this is really why Medicare, I think, is so excited about the CCM program when delivered appropriately. But in this example here, we wanted to do a total cost of care comparison, really an apples to apples comparison. And what we did is for this system that we worked with in the state of Ohio, we took a cohort of patients that were enrolled in our CCM program over a 12-month period, and then compared them to patients that had similar comorbidities during the same 12-month period that were eligible for the program, but for whatever reason were not enrolled in the program. And then we compared the Part A, the Part B, and Part D cost data for those two patients and wanted to see what the data showed us. So in terms of total cost of care, it was very interesting. If you look at it, we had a higher claim count per patient, meaning they were interacting and going to their office visits, having more claims that were actually paid out. But the cost was almost $2,000 less on average for the CCM enrolled cohort versus one that was not. It was a 22% reduction in total cost, which is really showing us that the program was really working as intended. We also wanted to take inpatient costs. So very similar, we took the Part A data to see when patients did have an acute event or they did have had to be admitted into the hospital, was there a delineation between those cost comparisons as well? And there was, very similarly, a 20% cost reduction per the overall cost with the inpatient interactions as well. Lastly, we also wanted to look at the pharma cost, the PharmD cost. What this really impacts patients, because that really there's a lot of this that comes out of their pocket. And similarly to the total cost slide, if you look at this, you see there onto the claims per patient, they're having more claims, and again, that's a positive thing because it means they're getting their medications, they're getting their refills, they're interacting with their providers versus the not enrolled cohort. But look at the total cost. Again, almost a 30% reduction in total cost PharmD costs, almost $1,500 on average annually per patient. So again, a very impactful metrics here with the program. Lastly, here, this is really important too for the communities where critical access hospitals or hospitals that you're having to treat these patients with these acute events. We wanted to track readmission rates. That's a metric that's very important for everyone. If you have patients that are readmitted, you don't get reimbursed for that. That's a major cost issue. Very similarly to the previous slides, we had almost a 50% reduction to almost 100% reduction in readmission, overall readmissions, regardless of the time period for the patients that were enrolled in the CCM program, again, for patients that were not enrolled. And that just goes right to the bottom line. It just shows that, again, the program is really working and doing the things that we all had thought when they rolled it out in 2015, but now we're actually able to see the data firsthand. So in late 2021, once we had a chance to see the actual final rule that was published in November to see how we were going to operate here in 2022, one of the things that we began to look at with the CCM program was how are they planning to expand it and how were they going to reimburse for it. And the really exciting news is that they're both expanding the program and there's a massive reimbursement increase that's just hit a couple days ago. If you look here at the quote here, I took this directly from the final rule. I think it's important to read out because it really kind of reads to, I think, the rationale of where CMS fits with this program. And as they stated here, it says we stated that accepting the updated values was consistent with our goals of ensuring continued and consistent access to these crucial care management services. And really the most important part is, and acknowledges our long-standing concern about undervaluation. I think they really felt like the reimbursement for the return on what these programs are providing for the taxpayer, for the organization's administration, and for the patient has been definitely undervalued. And I'm glad that they finally addressed that. If you look at the CCM program in totality, if you look at the codes, in 2015, it just had one code. It was just the 99490 code, the 20-minute code for care coordination. Since then, they have expanded it dramatically. They have added complex chronic care management codes for patients that need additional time and more complex comorbidities. They've moved into principal care management. These are more for specialists or patients that maybe have one chronic disease state, but it's not under control, and that can be done in parallel with the CCM program. So they've expanded it to roughly 10 codes now from the one. So they're continuing to listen to the providers and the staff and administration in our industry that are saying, we need more codes, we need more flexibility. This is really working well for us and our patients, but we need more of these. We need more ability to provide these services. And so this really speaks to they're listening to the market and expanding to 10 codes. In fact, you probably see that they're probably going to expand into additional codes in subsequent years. In terms of reimbursements, the reimbursements are going up pretty dramatically. Fee for service is going up quite a bit, almost 50%. But for rural health clinics in field-friendly qualified health centers and critical access hospitals, they bill under a different code. So they bill under the G0511 CPT code. Now, for the reimbursement increase from 2021, 2020, and 2021, the reimbursement was roughly around $65 in change for the G0511 code. However, with the final rule and even with some legislation that recently was signed into law just a few weeks ago, we've calculated the reimbursements this year to be upwards of a little over $81 and change. So you get a nice increase in that reimbursement. But the really nice thing about this is that there's no change in work. So they didn't require additional time. They didn't add other onerous confines to the program or requiring additional metrics that are needed for patients to be eligible. They've kept the code exactly as needed in terms of what's required to do and to be reimbursed, but they've just simply increased the reimbursement. So this is a really terrific time to really be evaluating this, if this is something that you've kind of been putting off to the side or didn't think that there was a viable option. So with that, we did want to talk a little bit also about if this is a program that you are really interested in 2022, finally spinning up, or maybe you've tried in the past, and really kind of understanding some of the nuances to it. This is things that we've learned over time ourselves over the last 6 years, really focusing exclusively on it. And so there's a handful of things that you really have to be thinking about. And really the mastery for this program to really be successful is really around the operational workflow. It's really not so much about software and spreadsheets. It's really about operationalizing it, making sure that the patients feel like that they have a program that they can feel comfortable with and that brings value for them. Those are really the key indicators to success. So as we kind of go through this, really starts with data integration. So you really need to be thinking about, if I'm going to use a third party, if I'm going to utilize the software platform, if I'm going to do it with my EMR, how do I get access to the data? How will they integrate with the data? And how will they extract what they need to identify the patients that are eligible for the program? As you move into eligibility, you then have to figure out, who's eligible. I need to understand that the patients have to be diagnosed to more chronic disease states. No, CMS doesn't require specific disease states. It's not disease management, it's chronic care management. So it can be any of the 10 to 15,000 chronic codes. The good companies will do things like stack rank your higher acuity CPT codes to ensure that you have the highest level acuity for those two codes. You have to have been seeing the patient within the last 12 months with an in-person office visit. And as long as they have that and they use Medicare as their primary insurance, Part B or Part C, they're eligible for the program. So to be able to go through that eligibility and then begin to educate and market to the patients. So one of the big barriers that we hear oftentimes with organizations that are looking at this program is, it's great. I understand the concept, and I think the concept is sound, but the first barrier for me is I got to figure out how to get patients into the program. It is a voluntary program. Patients have to elect to be in the program, like just about any Medicare program. So you have to have a very robust education and enrollment and marketing team. And it really requires things like providing education, videos, tangible marketing collateral that can really talk to the value of the program. What is it? Why did Medicare create it? Why is it something that I should look at? A lot of the companies will provide enrollment services. Medicare does allow for a telephonic outreach, and if a patient doesn't agree to be in the program over the phone, you can record that call and record it within the EMR. They can be in the program, so it doesn't have to be them walking into the office and signing a piece of paper, because that takes a lot of time to reach mass adoption. But all these things are kind of the initial things to kind of get set up that you need to kind of have continuously moving forward. That's why we say enrollment never ends. One of the things to be thinking about is that every state so far, pretty much across the board, including Indiana, is having anywhere between a 3 to 5% increase in Medicare patients overall net churning into the program annually. So your patient demographic, your patient population is changing. So if you have a net of 3 to 5% every month are coming into the program, that means you've got more patients, aging into Medicare than aging out. So you really need to be thinking about, okay, if I've got these new patients that are moving to my area, they're now in Medicare, you need to have a program in place to constantly be looking through this data to know who's eligible to the program, Because if you don't, you're going to have a churn out problem, and long-term success is kind of hard to achieve with this type of program. Then you got to move into the clinical engagement side of things. So the good companies that'll do this will offer a 24/7 program so that the patients have 24/7 access to their care team. It's a requirement of the Medicare program. It's making sure that they know that when they call at 3 o'clock in the morning and there's a major issue or there's something they need a question answered, they're going to get a live body. You have somebody that can follow proven protocols like Schmidt-Thompson, things like that, to triage appropriately, and then following up and making sure that those items are completed timely. And again, that's where it comes into, do you have the resources, the infrastructure, the telephony systems, everything in place to be able to be offered that 24/7. On top of that, in a couple slides, I'll talk about it a little bit further. In terms of population health, a terrific way to help with the quality programs, the cost reporting, and the different programs that you have to adhere to is to utilize the CCM program. So think of it as, I'm interacting with these patients. They're calling me, I'm calling them, we're interacting, I'm coordinating their care, kind of the quarterback for their care, not just at my clinic, but at other clinics. If I identify that there are certain care gaps that I need to complete, it's a great way to have that conversation and maybe move that process along. It might be colonoscopy, mammograms, pneumococcal vax, flu shots, whatever it might be, COVID vaccines or boosters. These are the types of things that a good care coordination program is absolutely set up to do, and it's a perfect use of that billable time. So you're not just getting the revenue from the billable time, but you're doing something that both benefits the patient in the practice and ultimately can maybe lead to better reimbursements or better performance in your quality programs. In terms of claims, you do have to bill it. You got to bill it every 30 days if you plan to be in the program. You can't really just hit repeat. You do have to create a new claim each month. At ChartSpan, for instance, we developed a proprietary program called Rapid Bill. And so what's nice about that is it does integrate with your EMR. It creates basically all of the manual entry automatic. So then you're able to review it and then submit it through your own system, but basically all the manual entries done for you. So that's really important because your billers do have a lot of claims they have to get out every month, and if you get behind, it hurts with your accounts receivable and then to be able to pay your bills. And so being able to do that in real time and get those out early in the month is also something that's very important. And the last two things you really be thinking about are things like quality performance. And so having a quality team that's dedicated to excuse me, listening into the phone calls, constant coaching, remediation. This is just like any other healthcare service. Whether you're a nurse or whether you're a specialist or whatever it is that you do, you want to really hone your craft. Do constant coaching, learn. You go to seminars. It's no different than care coordination. This is a place within healthcare. It's a subset of healthcare, and that's really what we spend a lot of time on is going back and listening to phone call interactions with patients, identifying through a rubric, where could there be improvement, where could you listen and identify issues maybe more effectively, looking at documentation. These are the types of things that to have a successful program you really need to have in place. And then really patient services is a department where, like if a patient has a question about their EOB, maybe they don't really understand the program. This is new to them. It's really new to the market in general. A place that they can call and have that conversation. That's something that we have available as well. Another thing that we're finding too is that as the patient demographic is changing, as more and more younger Medicare patients are rolling in, is they want to utilize technology. They want a multimodal approach, and that's kind of a fancy term for saying, I want to be able to text. I want to be able to use a web application, maybe email. I don't want everything just to be over the phone. So, being able to offer those different services that you can do is really important, and it really will help patients have other ways to engage. And it's little things like, if you have the ability to set up a text function that you can send out that just says, hey, have you been to the ER, had a change in medication, or or seen a specialist in the last 30 days? Yes, no. Believe it or not, that interaction is very helpful to the program in engaging with the patients. It is very simple. If it's a yes, then we want to follow up. If it's a no, great, we log that, and we know that we were able to interact, and they know we're checking in on them, and it's not intrusive. So these are little things that we're finding that patients are responding to, and I think having these different multimodal approaches again is really important as we move further into this program.
Shane?
Yes.
I'm sorry to interrupt, but we did get a question in the Q&A. Can you clarify the differences in the processes of determining patient eligibility and consent for RHCs? It's my understanding from CMS, RHC, CCM, FAC that those steps cannot be done by a vendor, but must be done directly by RHC providers and staff.
That's been, I believe that has been delayed. I believe that there was discussion on that. I don't recall if that was part of the PHE. I'd have to follow up on that. That's been raised many, many, many times. I'm pretty sure that that's not the case, but I will need to follow up on that. I haven't had that question posed in quite a while. Moving to the next thing. So what you also want to be able to do is to talk about educating patients about CCM, and that's also really important as well, and making sure that you have things that you can send. Just reaching out, or whether you're doing it through the RHC, whoever is interacting with them, you want to be able to provide things that can help them understand and soften this, this interaction. Things like VOAPs. VOAPs, for instance, is a thing that you can put a voicemail onto, have a provider record a 12-minute voicemail, 12-second voicemail that you can put onto the patient's phone, things like that. They can just explain what the program is, making sure they get something tangible. If they do enroll in a program, you do want to make sure that they have the ability to look at something that they can understand. It's kind of like when I first got my Amazon Alexa, that you get that, what questions do I ask? How do I utilize this? It's very helpful to know kind of the top 10 things. So you want to provide certain things like that, videos, emails, again, really to soften and provide that brand awareness of what your program is. And then to make sure that you understand that the patients have the ability to say, okay, when the phone call does happen, or whomever does talk to me about it, I know a little bit more about it and what the value is potentially for me. The other thing to be thinking about is patient churn. I mentioned that earlier, and so patient churn is really important, because if you don't affect the back end and front end of churn, a program can ultimately really suffer. And so patients are going to churn out of the program. That's inevitable. Patients will die. Patients will go into long-term care, dialysis. They move. These things will occur, and some patients will just unenroll. It's not a program maybe that was right for them. So ensuring that you're constantly looking at the patient programs that are coming in, making sure that you're identifying patients that are able to potentially enroll into the program, that's really important. So if you have that machine turned on, if you're constantly looking through that, you can ultimately keep a nice sustainable program that can keep that patient churn in the positive versus the negative, and you can have a nice sustainable program that you can count on. The other thing we want to talk about was the quality improvement services. And again, this is what we mentioned earlier about support for closing care gaps. So one of the things that we do, and we were very effective with this, is being able to take things we work with, the population health or the quality department of an RHC or an FQ or whoever we're working with, is to identify where are those care gaps, where are you needing improvement and maybe in a specific quality measure. And so essentially what we will do is we'll take those reports, we'll upload that and match that to patients that are active in the program, and then upload those as kind of like to-do lists, to-dos that will cue the interaction between the clinician and the patient, so that when the appropriate time is right, they can insert that discussion point, maybe ask that question about whether it's a mammogram or whatever it might be, have that conversation with the patient and just say, is this something that you're interested in? I'm happy to help follow up on it, or maybe it's something that you've had done. That's chart chasing is something that we spend a lot of time on. They say, I had that completed last year. Well, where did you have it done? And so we'll follow up with that, pull down that CCDA from that provider, and then make sure that's sent back to the rendering provider of the CCM program, so that they can get credit to say, yep, this patient did get this completed over this time period. So there's really kind of two ways to attack it, but again, it's a terrific use of the CCM program. These are just some of the examples of kind of the main heavy hitters of the measures and programs that we all really understand. In terms of forecast, if you think about financial impact here too, I think that's something that we think about quite a bit. And if you think about the new code, we wanted to run some numbers. So there's a cost allocation to running this program, whether you're doing it yourself or whether you're outsourcing it. So we wanted to provide an example here that if you were able to have an organization, let's say, that had 1,000 patients, and the average eligibility percentage is around 82%. We've seen it higher, we've seen it lower, but that's typically the national average for patients that are eligible. if you were able to get roughly 50 to 55% of the patients enrolled in the program, what does that mean, in terms of financial impact for your organization with that reimbursement rate? So like, for instance, like as an outsourcing partner, if you wanted to take, what our rates are with the minus the reimbursement, we would forecast that at about 200 to 215,000 in net year one. That incorporates ramp up period times, our historical data. And also what we've also seen through the claims data that we have is that we're seeing anywhere between 8 to 10% increase in E&M visits. And that's a direct correlation to the program. And that's, again, getting patients in for more visits. That's, removing barriers, whether it's social or clinical in nature. But, realistically, the total opportunity or potential impact in year one in this example could be, almost $250,000 to $225,000 really in net opportunity, for the RHC. So with that, relatively quick, I know that's everybody loves PowerPoints, but I wanted to touch on the salient points. My colleague Karen this is her contact information. If anybody has any questions or would like to continue a conversation or learn more specifically about the organization, happy to have that. There's her contact information. Reach out to Karen. And other than the chat question, if there's any other questions, I'm happy to answer.
We haven't had any other questions come in via chat or Q&A, but certainly happy to take any more now. We'll go ahead and leave the line open for a couple minutes if somebody's typing. We can also allow you to ask a question vocally. If you would like to ask a question with your microphone or your phone, just use the raise hand function, and Carolyn or myself will be happy to unmute you and allow you to ask your question directly. While we wait, just really appreciate your time today, Shane and Karen, you being here to answer questions as well. Really great information for our members. As I said, we will have that recorded and posted to our YouTube, so potentially you may see some extra questions come in next week. But I know I got a lot of information that I didn't have from this, so.
It was our pleasure. We really enjoy having a chance to visit about this topic.
Well, not seeing any more come in, so I appreciate everybody joining us today. Hope to see you on some of our future Lunch and Learns, and wish you all a very happy New Year and a great afternoon.
Thanks, everybody. Have a great day.